1 gram of HA absorbs 3 liters of water. So it seems to be there into tissues that require fluids, not only water, but fluids and cells to move like a big empty sponge that enables tissues to grow. I mean, at that time when I arrived at UCLA, already HA was into morphogenesis, in tissue repair, in fracture sites, osteogenesis, calcification, and last but not least, fetal surgery, as we talked about before. So hyaluronic acid is into 4 crucial steps of tissue repair and regeneration, mostly regeneration. The blood clot, inflammation, proliferation, and remodeling. And we'll see that these 4 issues of tissue regeneration and repair are very crucial, especially in our hands when we play with periodontal tissues. And we published that HA has a role in creating calcification of the bony cells when they're close into ready to get into confluence and form an osteogenic area. So 1998, the first publication on bone regeneration and bone growth. 1998, we look at the bacteriostatic effect of HA. Before then, the most of papers were looking at hyaluronic acid, something that would also almost create a good environment for bugs to grow. We were the first one saying that it has a bacteriostatic effect that can be postponed, put into the application of the same into the periodontal environment. 2003, we looked at the effect of HA at the calcification of periodontal ligament in cell culture. So little by little, we were moving into from as a translational movement from the laboratory to the clinical practice. And this is why 2011, a first randomized controlled clinical pilot study looking at the efficacy of HA in periodontal clinical parameters. Now, very close to now, 2018, thanks to a big group of people, thanks to us and to them, the University of Bern, University of Zurich, we looked at the Miller class 1 single gingival recession sites in a randomized controlled clinical trial type of study to see the application of HA in the mucogingival application. And now, very recently, we submit a paper, and thanks again to the group in Sapienza and Tony Sculian and others, looking at 24 months healing of infrabony defects. So looking at the regenerative surgery. 2 issues that are very important are cell migration and clot stabilization. Cell migration meaning cells that need to move from one area to another one, and clot stabilization because we all know how central is the role of the clot that has to be stable within the area. Clot and hyaluronic acid, we've seen that before. But let me show you just a few of the hundreds of papers related to HA and clot formation. This is 1995, a very important journal that observed the inhibition of clot lysis, but also a stimulation of clot formation by hyaluronic acid. Many years ago, research started to prove the increase the tensile strength of granulation tissue by the application of hyaluronic acid. Significant power to the increase of tensile strength. Science, 1985. The angiogenesis is induced by the degradation products of HA. So angiogenetic power into the area. And that's science. This is matrix. Hyaluronic acid interactions with hydroxyapatite do not interfere with the hydroxyapatite crystal proliferation and growth. So if we are into osteogenesis, we need HA. Last but not least, is a vehicle for peptide growth factors, many of them. We apply the biomodulator HA in a few seconds, let's say in a couple of minutes, we immediately see that the clot is stable and forms and creates a sort of meshwork, a mesh that is stays there stable, ready to play with cells. So this is something that we want to take into consideration, not only to say and to see how the healing is fast and nice, but also from the patient perspective, the good use of that. This is a 1-year follow-up. And of course, so we raise the flap. This is the exposure of the root. This is the application of the of a layer of gel of HA in form of gel. This is 1 minute later. 1 minute later. This is now you see 2 minutes later, and the blood seems to crawl over and underneath and within this gel. We advance the flap, and of course we had a nice healing, but mostly the patient post-op very little discomfort. Let me show you just one paper that was published in 2012 saying that the fetus is like a sponge of HA with cells, of course, that seems not to create, in case of wounds, any type of scarring into the first 2 trimesters of pregnancy. So this risk of creating scars starts only from the 3rd trimester of pregnancy and on in the adult life. So something there with HA must tell us that we could utilize this information. I was kind of fascinated by looking at the quality of the healing that we can see on a clinical basis, scar-free in some areas and very little scar formation in some others, the timing and so forth. And you know that this is very much evident in the clinical situation when we manage the soft tissues for periodontal or implant purposes. In 2018, looking at the effectiveness of HA by using the coronally advanced flap and cover the root when it's exposed. So we, in this study, divided the patient in 2 areas. We took test side, the control side. We looked at gingival recession, class 1 Miller class 1. We located the gingival margin. We located the depth of the sulcus. We located the mucogingival line. So even in case with very little presence of attached gingiva, we selected these cases for a coronally advanced flap, putting underneath the flap, as you can see now, a very efficacious molecule that should play with cells and clot and speed up the healing. So we raise the flap, as you know, which is full and a split thickness, so we can passively move upwards, in this case, or downwards for upper jaw recessions, and close the area. How can we conceive root coverage techniques or mucogingival surgery plus hyaluronic acid? Well, we know that by applying this molecule, we are into, as I said, blood clot, monitoring the inflammation, cell proliferation, and remodeling. And we'll see that what we do clinically should match the biology. We have looked this also into the multiple recession areas. This is another case, the application of HA over the root surface, and I'll talk to you very soon about the difference with other biomolecules. The 2 minutes later, we wait for about 2 minutes, then we close, passive and not without tension flap. This is the healing at 24 hours. See, there is no redness, there is no tension of the flap, and it looks very nice at only 1 day after the surgery. And this is the evaluation at 18 months, the before and after. And also we are running a study looking at the effectiveness of HA when there is the need of a connective tissue graft in Miller class 2. So there is the need to put a graft, connective tissue graft taken from the palate with HA and a flap without tension. This is the healing at 12 months. So let's now move into the other area of periodontal surgery, and let's see if there is some benefit in the infrabony defect treatment. Okay, so we're talking about now of periodontitis with lesions that are deep, that require not only an access flap to remove the granulation tissue, but mostly tend to regeneration. So what happens if we apply HA, a graft, into a specific infrabony lesion, and what can be the expectations we have by the combination of HA and the graft? Well, let me tell you one thing. First of all, HA can be applied with blood, in presence of blood, because we know that the role of HA is strongly related to the importance of the presence of the clot and clot stabilization, clot stability. Now see how the clot gets stable and becomes a net. You can almost visualize this net of clot. Then we apply our graft. We apply the graft in order to fill the area. Before and after 1 year re-entry, that was done because of the need of covering the root. Okay, so I get the chance to visualize what happened at 1 year. This case shows you, I want to present you this series of pictures with another sandwich technique in a posterior area, where you can see that only already at 72 hours time, the healing is really nice, with no inflammation of marginal tissues, and from baseline to 6 years, a nice growth, gain of attachment. We now need clot stabilization. We need this molecule to immediately interact with fluids, with cells, and of course we implement the area with the graft. Okay, so very quickly we put the graft and fill nicely the defect. So this is before the application of the combination of graft and HA. This is another case, just to tell you that sometimes we're lucky also for super bony defects, but let me tell you how difficult it is to treat super bony defects, again in the combined method. This is another case, and this is a case that shows you that even when you lose some tissue, but the regeneration occurs underneath, little by little, 6 months, 12 months, and 18 months later, you see coronal growth of tissue between the elements, the covering of the roots, and the gain of attachment. This is another 7 years post-op case. Some of us have also tried to use HA alone. This is one case of 5 years from baseline that we presented at Europerio in Amsterdam a couple of years ago. Another case that belongs to the study that we're publishing with Tony Sculian at 4 years. And a final study that was published in January 2019, looking at cemental tear associated bony defects, like this case report, where at 2-year follow-up, we could see the use of HA and a resorbable collagen membrane without a graft material and the complete regeneration of that area that was missing around that element. Well, the defect is not a disease, it's a cemental tear, but very efficacious, the treatment.